from the Royal College of Surgeons in Dublin. So Jonah, thank you.
Thank you very much, Sarah. Can you all see that? Can you hear me okay?
We can hear you. Thanks, Jonah.
Great, thank you very much. So my name is Jonah Byrne. I'm a PhD student in the Department of Psychiatry in RCSI, and I'd like to present my work investigating transdiagnostic inflammatory subgroups based on peripheral biomarkers. So the inflammatory hypothesis of psychotic and depressive disorder has been quite an attractive hypothesis, I think. And there's been a lot of research in recent years and with mixed results, but meta-analyses have shown that at least certain cytokines such as IL-6 and TNF-α are modestly increased after adjusting for confounders such as sex and BMI. And this research has fueled clinical trials of anti-inflammatory therapies as augmentation to SSRIs or antipsychotics. And there's been a call for future trials to target patients with increased inflammatory profile. There's been two clever studies that have addressed the question of whether subgroups exist in psychotic or depressive disorder, looking at the variability of cytokines. And they found that the variability of cytokines wasn't higher in psychotic or depressive disorder than controls, which really, if there were subgroups, we would expect the variability to be higher. So we wanted to address this question further, taking a multivariate approach and also addressing it transdiagnostically, as we didn't think that any inflammatory subgroups would adhere to diagnostic boundaries. Our study is based on the Avon longitudinal study of parents and children, which is a large, well-characterized study following a number of children from birth past the age of 25 now. And we designed a nested case control study within the study. Our psychiatric disorder group consisted of a number of individuals with psychotic disorder, generalized anxiety disorder, moderate severe depression, and interestingly, 30% of these had more than one disorder or met criteria for more than one disorder. And our controls then, on the other hand, had next to no psychiatric symptoms. We measured a number of inflammatory biomarkers with ELISA, including a number of inflammatory markers, acute inflammatory markers and cytokines, adhesion molecules, the putative chronic inflammatory marker, suPAR, and the inflammatory regulator, alpha-2 microglobulin. For our data analysis, we chose a semi-supervised clustering method, which you may be familiar with from Paris's excellent talk earlier. And we chose this method because it has the potential to real subgroups that are specific to psychiatric disorders by using controls as a reference population. So to explain this a little bit further, on the left, we can see a support vector machine with a linear classifier classifying patients from controls. And on the right, we can see HYDRA taking a slightly different approach using multiple linear classifiers, and patients then being distinguished from controls for different reasons. And the clustering assignment is then elucidated by the association of patients with size of the shape that remains. This is an excellent method, in my opinion, because covariates can be added and allows for robust internal validation. So we ran HYDRA with 100 cross-validation folds and estimated the mean adjusted random index from these cross-validation folds. The adjusted random index is a measure of clustering stability, with a higher score indicating a greater stability or reproducibility. We searched for between 2 and 6 clustered and adjusted to model for sex and BMI. We found that our highest ARI was for 2 clusters at 0.27, which is quite a poor score. And our clusters did not explain the biomarker distribution better than the Gaussian distribution. We repeated the analysis by randomly labeling controls with a fake psychiatric disorder status or a normal control status in a similar proportion to our original experiment, and carried out the clustering again and found we were able to achieve a very similar score as we were with our initial experiment, and indicating that the clusters we found initially could be found by chance. In conclusion, this study found no evidence for the existence of transdiagnostic inflammatory subgroups based on peripheral biomarkers, at least when controls were used as a reference population. The study had a number of limitations, including, well, I wouldn't exclude that the possibility of inflammatory subgroups based on longitudinal trajectories in inflammatory biomarkers, but we did have a number of strengths. including a large, well-characterized study based on the AFN longitudinal study. We measured chronic and acute inflammatory markers and used what I think is an excellent clustering method that uses controls as a reference population. Thank you very much for listening. I'd like to thank my colleagues and welcome any questions or comments.
Thank you, Jonah.